ಇಲ್ಲಿ ಕಷ್ಟ ಆಗತ್ತೆ ಇವಾಗ ಪೀಪಲ್ ಆರ್ ಕೀಪಿಂಗ್ ಟ್ರೀ. Okay, shall we start? It's exactly 6 o'clock.
Yeah.
ನಾನು ಹೇಳ್ತೀನಿ ಅವಾಗ ಹೋಗಿ ಒಂದು ನಾನು ಇದು ಸ್ವಲ್ಪ ಸೆಟಪ್ ಮಾಡ್ತಾ ಇದ್ದೀನಿ.
Okay.
Rajendra, can you admit those who are on the waiting list? I can't access them now.
ಇದೇ ಪ್ರಾಬ್ಲಮ್ ಆಗ್ತಾ ಇರೋದು ಇವಾಗ.
ಸುರೇಶ್, co-host option ಇಲ್ವಾ?
ಇಲ್ಲ.
ರೂಪಾಜಿ ನಮಸ್ತೆ.
ನಾನು ಹೇಳ್ತೀನಿ ಅವಾಗ ಹೋಗಿ ಒಂದು ನಾನು ಇದು ಸ್ವಲ್ಪ ಸೆಟಪ್ ಮಾಡ್ತಾ ಇದ್ದೀನಿ. ಓಕೆ.
ಕವಿತಾ ನಮಸ್ಕಾರ, ದಾವಣಗೆರೆ ಟೀಮ್.
ರಾಜೇಂದ್ರ ಇಟ್ಸ್ ಆನ್ ಲೈವ್. ಸ್ವಾಮಿ ಒಂದ್ಸಾರಿ ನೀವು ಯೂಟ್ಯೂಬ್ ಲಿಂಕ್ ಚೆಕ್ ಮಾಡ್ತೀರಾ ವರ್ಕ್ ಆಗ್ತಾ ಇದೆ ಅಂತ? ನಮ್ಮ ಗ್ರೂಪ್ ಅಲ್ಲಿ ಲಿಂಕ್ ಇದೆ ನೋಡಿ.
Can you mute them, Rajendra?
Yeah, done.
Yeah, it's working.
Okay.
Suresh.
Can you ಇದು ವಾಯ್ಸ್ ಇದೆಯಲ್ಲ? Okay. Can you just check the voice as well at the same time?
Yeah. Yeah, I can hear you.
Okay, that's fine. Rajendra, everything is ready.
ಅಲ್ಲಿ ಏನೋ ಸೆಟ್ಟಿಂಗ್ ಚೇಂಜ್ ಮಾಡಕ್ಕಾಗತ್ತಾ? So they can join automatically rather than we admit them.
ಮಾಡ್ಬೋದು. ನೀವೇ ಹೋಸ್ಟ್ ಅಲ್ಲೇ ಮಾಡಿಬಿಡಿ. ನೀವು ಕಾರ್ನರ್ಗೆ ಹೋಗ್ಬಿಟ್ಟು ನೀವೇ ಹೋಸ್ಟ್ ಅಲ್ವಾ, ಅಲ್ಲಿ ಇದೆ ನೋಡಿ ಆಪ್ಷನ್ಸ್ ಇದೆ, ಅದನ್ನು ನೀವೇ ಮಾಡಿಬಿಡಿ.
I can't see the option.
Okay.
ಹಂಗಾರೆ ಒಂದು ಕೆಲಸ ಮಾಡಿ, ತಿಪ್ಪೇಸ್ವಾಮಿ ಹತ್ರ ಸ್ಲೈಡ್ಸ್ ಇದೆ, ಅವರೇ ಶೇರ್ ಮಾಡಲಿ, ಅವ್ರನ್ನೇ ಹೋಸ್ಟ್ ಮಾಡಿಬಿಡಿ. ಆಗುತ್ತಾ?
ಓಕೆ. ಯಾರಾದ್ರೂ ನೀವಾಗಲಿ ಅಥವಾ ತಿಪ್ಪೇಸ್ವಾಮಿ ಯಾರಾದ್ರೂ ಒಬ್ರು ಶೇರ್ ಮಾಡ್ತೀರಾ ಸ್ಕ್ರೀನ್?
ತಿಪ್ಪೇಸ್ವಾಮಿ ಹತ್ರ ಇದೆ, ನನ್ನ ಹತ್ರ ಇಲ್ಲ.
Okay. ಇದು ಡಿಸೇಬಲ್ಡ್ ಆಗಿದೆ ನಂದು.
ಹೌದಾ? ಒಂದೇ ನಿಮಿಷ.
Are you done?
Yeah.
Can you see the screen?
Yes, I can.
Yes.
Yeah.
Okay.
Perfect.
ಎಲ್ಲಾನು ಮ್ಯೂಟ್ ಮಾಡಿ. ಇದು ಯಾವುದೋ ರೂಪ ಅಂತ ಇದೆ ನೋಡಿ, ಅದನ್ನು ಮ್ಯೂಟ್ ಮಾಡಿ ಪ್ಲೀಸ್. ಓಕೆ, ಫೈನ್.
ಅದನ್ನು ಪ್ಲೇ ಮಾಡಿ ಹಾಕ್ತಾರೆ. ಇಲ್ಲ.
Can you see?
Okay.
Yes.
ಅದು ಮೊದಲೇ ಸ್ಲೈಡ್ ಇಂದ ಹಾಕ್ತೀರಾ?
Yeah. Okay, shall we start?
Yeah.
Good morning, everybody. Welcome.
Good morning, sir.
Good morning. We welcome you all
Morning.
on this. We welcome you all on the GINA platform. This is a dedicated platform for student nurses, clinical nurses, and teaching faculty to learn and share evidence-based practice. We welcome you all on our 5th month session. I welcome Mr. Rajendra Irani, who is a registered general nurse and a nurse practitioner currently practicing in Ireland in the emergency department. Rajendra is going to take us through burns management and the journey of the patient and how about its management. Over to you, Rajendra.
Thank you.
Rajendra, before you start, one announcement.
Okay.
So our Zoom platform is reaching 100 nearly. Already we are in 96. We have got capacity of 100 only. If anybody unable to join, so please use our YouTube link and also Facebook link as well. That's your request to you all. Thank you, Rajendra, please.
Thank you. Next slide, please. Good morning to all. So I'm going to discuss regarding the management of the burns, but we'll try to focus more on the emergency management of the burns. That is, what will happen or how to take care of the patient. Can you unmute the So
I have.
how to take care of the patient when the patient comes to the emergency department. So can you mute Kalyani Singh, please?
Can I ask all the audience to please keep your mics on mute, please? Right. Sorry, Rajendra, carry on.
Okay. If you have any questions, please type in the chat box, either in the YouTube or in the Facebook or in the Zoom chat box, and we'll get back to you at the end of the session. I request all of you, can you mute mics, please?
Done.
Okay. So first of all, I'm not going in detail regarding the anatomy and physiology of the skin or anything. Just will try to go to the clinical management as quickly as possible. So first one is functions of the skin. Why do we need the skin? So that's for the thermoregulation, that is maintenance of the temperature, prevention of the fluid loss from the evaporation, and also skin will protect from the infection. It acts as a barrier, and also it protects us through the sensory stimulation, providing sensory information. For example, if you're touching any hot or cold, it gives the information. So suddenly we can withdraw of hand or body from the source of injury. So that's also one of the important function of the skin. So it's having the 3 layers. Important, you have to remember the epidermis, dermis. Oh, I can't use the pointer because I'm not the host here. So you can see at the first layer, the epidermis, that is the topmost layer, and the second one is the dermis, that is the secondmost layer. Then comes to the epidermis. Epidermis means below the skin, mainly the subcutaneous. So these 3 layers, forget about all other layers, just remember epidermis, dermis, and lastmost, the last layer. Okay, so these layers will help us to determine the degrees of burn. Next slide, please. So there are a few types of burn injuries, and when you open the book, different text will categorize in a different way, but we'll try to simplify it as much as possible. So one is what is burn injury? A burn injury is a type of injury to the skin or to the muscle caused by the either heat, electricity, chemical, friction, or radiation. So types of burns includes thermal burns, that is direct contact with any source of heat. Either it can be a flame, or it can be a liquid, or it can be a steam, etc. So any source of heat, direct contact with the heat. Next one is electrical burns. So electrical burns can be with alternating current or the direct current. So usually at home it will be the alternating current, and whereas in the industrial or in the lightning, so they are all direct current. So that will be the more dangerous compared to the alternating current. Next one is chemical burns. In chemical burns also there are two types. Main source is alkali or the acidic. So usually we'll see the burns with alkali at domestic one. Like most of the things, what we'll use the bleach, they are the more alkali. So more alkali are more, it more penetrates more deeper compared to acidic. It looks initially normal, but penetrates more deeper, especially soft tissue, especially when you consume the alkalis. Second one is the acidic, sulfuric acids. That's one of the most dangerous acidic, and usually we see in the industrial accidents. Second one is the radiation. Common one is sunburn. Usually sunburn causes the first degree burn, whereas other radiation, even especially if you're in the theater, in the advanced way, they are using the UV radiations. So that's also causes the burn, especially the burns to the eyes. Next one is friction. So friction will be commonly seen in the children, especially during the hot summer days when they're using the slides, or when they're using the swing ropes, and if they're falling from the holding the swing rope, and when they'll fall, we can see the friction burns on the hands. Next slides, please. So inhalation injury. So this is the most one of the important, which we are going to discuss in detail in the coming at the end of the session. We are going to discuss regarding the inhalation injury, regarding the carbon monoxide injuries or other chemical injuries. I'll discuss that one at the end of the session. Next session. So burns can be classified depending upon the depthness of the injury, or depending upon the amount of body surface area is affected. So as I mentioned, you have to remember three: epidermis, dermis, and hypodermis. Epi means topmost, dermis means mid layer, hypodermis means below the dermis, where this we can see the subcutaneous tissue. Next one is underneath the hypodermis is the muscles, then the bones, tendons. So the burns can be classified depending upon the depth into the four categories. Basically, yeah, first degree, second degree deep burn, and the third degree. So don't get confused here, second degree here, because second degree superficial, second degree deep. So I'll come back to that one also. You will understand at late stage more. So in first degree, only the topmost layer, that is the epidermis, is involved. So usually it will be first degree and commonly seen in the burns or the superficial scalds. Whereas the second degree superficial, it includes the epidermis as well as the part of the dermis. You can see still there is the, you can see here, hair follicle still will be intact in the second degree burns, second degree superficial. Whereas the second degree deep burns, you can see there the hair follicles also will be destroyed along with the blood capillary vessels. Whereas in third degree, epidermis, dermis, and it will extend up to the hypodermis. In this case, there will be complete loss of tissue, and this one needs the grafting, definitely. And it will extend up to the, even the next degree burns will extend up to the muscles and the bones also. Next slide, please. The first degree involves, as I mentioned, involves only the top layer of the skin, that is epidermis. So tissues will blanch with pressure or good capillary refill. For example, if you press the skin and if you release the pressure, just press the skin over the affected burn area and count 5 seconds and release the pressure, and you can see the capillary refill. Initially, the area will be white and the blood will refill again. So that means the capillary refill will be present. Sometimes it will be slightly reduced, but still it will be present. And all the tissues will be the red or pink, and it's usually painful because there won't be any damage to the nerve endings. So still the person can feel the pain very badly. So first degree burns will be more painful compared to the last degree one. So it involves the very minimal damage to the skin with no blisters. So in first degree, absolutely no blisters, no scars will be left behind. Usually it will heal very quickly in 5 to 7 days without any scarring. Next slide, please. Second degree burn, as I mentioned here, it's considered as only the partial thickness burns and involves epidermis and the portion of the dermis, not the complete dermis. If it is epidermis and dermis both are involved, then it will be a second degree full thickness burn. This often involves sweat glands, hair follicles, blister present, and it will be very painful because still the nerve endings will be intact. Blanching still it will be present and may need the skin graft if they deep partial thickness. And it takes at least 3 weeks, 3 weeks time to heal. And always, most chances there will be scarring will be left behind when this wound heals completely. So in the second degree burn. Next
Sir,
slide.
please join. We are waiting.
Next one is the third degree burn. Usually refers the full thickness burn. In this case, epidermis, dermis destroyed along with the hair follicles, sweat glands, and nerves also will be destroyed. Here, the patient will be having very less sensation or no sensation of the pain. So it extends hypodermis, that is subcutaneous. That means the whole thickness of the skin will be destroyed in the third degree burn. So it can look black, yellow, red along with the coagulated vessels. You can see in the second picture. So not painful because it won't be painful because most of the skin will be damaged. But still sometimes nerve ending may be uh, intact surrounding the burn. So the pain will be severe because imagine if this part of this hand is burned completely, third degree burn, but the surrounding skin will be intact. So that surrounding skin may be second degree burn or first degree burn. So still the pain will be very bad surrounding the third degree burn. And skin will not heal in the third degree burn. Definitely it needs the skin grafting. Next slide.
Sorry, before you go to next slide, can I request the audience in Davangere SS College, if any of you have logged in from the phone link, can you kindly log off because there are a lot of students are waiting on the Zoom link. If you can watch it on the bigger screen, please log off from your phone screen, please, because you are watching already on live, so you're logged in two places.
No, I think they need it once because at the end for the
no, they can re-log in. But I got more than 100 participants, so I'm unable to admit them. Sorry.
Or they can log in the YouTube from the Davangere SS Hospital.
Yeah.
For the participation.
Yeah. Thank you.
Thank you for your cooperation. Next one is the fourth degree burn. So this is the worst of all. So all the layers, that is 3 layers are destroyed completely and it extends to the muscles, ligaments and the bones will be, most of the times bones will be visible and no sensation and it needs graft, sometimes amputations. So next slide. So earlier I mentioned burns can be classified depending upon the depthness, first degree, second degree, third and fourth degree. And depending upon the severity, it can be classified into the major, moderate and minor. So again, you can see there's a partial thickness and the full thickness burns. So if the partial thickness more than 25%, whereas full thickness more than 10% considered as major, and these patients need to be treated in the burn unit or the burn care center. And whereas the moderate, again, you can see directly in the chart, 15 to 25% of the partial thickness and more 10% of the full thickness is considered as moderate. And this patient needs the hospitalization, not necessarily in the burn unit, but anywhere in the hospital, but they need the hospitalization. Whereas minor burn, that is partial thickness less than 15% and the full thickness less than 2%. So usually these patients can be treated in the emergency department or in the outpatient settings. Next slide, please. So burn extent evaluation. How we are going to evaluate regarding the percentage of burn? So one is we have the different formulas to calculate the percentage of the body surface area which involved in the burn injury. Burn extent is calculated. Remember, percentage of the burns will be calculated only in the second, third degree burns, and second, third, and fourth, but not in the first degree burns. And it can be roughly have the different rules. First one is the palmar surface, especially commonly used in the children. So palmar surface means, imagine 2 year old child comes to a burn injury, and you're not in a position to measure everything, calculate everything. Just use the patient's palm, not fingers, no thumb, no other fingers, only the palm. So this is usually considered as the 1% of the burn. So if you keep that much area, so that is 1%. This is very approximate method. It's not accurate. Second one is the rule of 9, which commonly we are using in most of the settings. And second one is the Ilun Browner, that is more accurate. This is the extension of the rule 9 estimation. And the rule of palm, it's applicable to the adults also. Rule of 9 means that this is the palm of the patient, not the palm of the examiner, not the doctor, not the nurses. It's the palm of the patient is considered as 1%. But personally, I won't recommend that one. Ideally, we have to go rule of 9 or the Lunded Broader. That's more accurate because that will determine the fluid resuscitation. So, okay, next one. So this is the rule of 9. You can see here the biggest difference is that if you go to the adults, the head, that both front and back considered as 9%, whereas in children it's considered as 18% because their head size is more compared to the body in children, whereas in adults it's other way around. Next slide, please. So there are few factors which affects the severity of the burns. For example, the higher the body surface area is involved, higher the severity, as I mentioned earlier. So percentage of total body surface, depthness of the injury, that is first degree, second degree, third degree, fourth, and age. The outcome of the burn injury is severe in case of children and elderly, and also certain patients with a medical history such as diabetes, heart failure, and the way the burn injury is involved, either in the face, neck, torso, perineum. So these are the more critical areas. If the injury happens to the legs, yes, I know it may not be life-threatening, but still there is a time to deal with that one. But if it involves face, it's highly critical. Neck, torso means chest. That's one. I'll tell you regarding the when I'll explain regarding the sclerotomy at the middle of this presentation. Next one, please. So how the burn injury can affect our whole body? It can be electrical injury. The person can get electrocuted and get the burn injury, and only the point of at the point of entry and the point of exit only we can see the two wounds. But there's a whole major pathophysiological changes will be taking place inside the body, or even it may be injury from the first degree, second degree, third degree. So still this cascade will activate. So if you see that one, exposure to the flame, heat, cold, chemical, radiation. I'm not going to cover the cold one. Cold one means it's usually the frost bites. So I'm not going to, or in the certain liquid factories where the liquid nitrogen is involved, that is usually at minus 80 degrees. So that will cause us also severe cold burns. We can't touch that one with the hand. So that is a different one. Usually we won't see in India frost bites, except unless we are there in the Himalayan belts. So what will happen? Usually there will be loss of function because of the loss of skin and the disfigurement. This is the disfigurement is the chronic one, whereas the loss of function is immediate. So what will happen to the if the damage to the nerve, if it is a superficial, then there is a neuropathic pain. So the pain will last for longer time. If it's complete loss, then there won't be any pain. So permanent loss of nerves because the nerve cell won't regenerate. Second one is local inflammation in response to the burn damage. So there is the increased permeability, extra laceration of the fluid. There is high risk for the fluid loss, severe fluid loss, and hypovolemic shock. And you can see there is a multiple cascade Even because of the loss of skin, there's a loss of heat, the patient will go to the hypothermia. Because of the loss of fluid, hypovolemic shock. And because of the massive pulmonary edema, because of the increased permeability of the blood vessels, there's the increased inflammatory cascade will develop, and that will cause the distributive shock. And because of the loss of skin, there is a high chance for the local infection or the systemic infection, and that will cause the sepsis, and that may cause the septic shock. So this not the only one system is affects; it's a multiple systems affects because of the burn injury, and one of the worst outcome will be the that is acute respiratory distress syndrome and the end organ failure. So we can avoid most of the things, the complications, that is hypothermia we can avoid, sepsis we can avoid, end organ failures we can avoid, and DIC, that is disseminated intravascular coagulation, can be avoided with the proper treatment in the emergency department as well as continuation of the treatment. Next slide, please. So what are the basic investigations we have to carry out? So the blood test. So in the blood test, we can see most of the burns patients, especially second and third degrees, there will be increased hematocrit values will be there because of the loss of fluid. Hemoglobin will be reduced because of the lysis, that is the destruction of the cells. There will be increased sodium, so decreased sodium and increased potassium level because of the fluid shift and the cell lysis. Blood urea nitrogen will be elevated because of the hypovolemic status and the protein catabolism. CK, this is one of the important indicator, especially in case of the burn injury, because if it is a flame injury from the flame, we can see the burn injury extensively with our naked eye. But if it's electrical injury, usually we can see only the injury at the point of entry and the point of exit. Only two burn points we can see, and we'll assume that there is no much damage. But when you see the CK level, that is the creatine kinase level, higher the level indicates the higher the damage to the muscles, and that also causes the renal failure, because what will happen is that the myoglobin will be released to the bloodstream, and your kidney won't be able to filter it out. So that will cause the acute tubular necrosis. So we have to be very mindful in case of, even though no matter how severe it's electrical burn, we have to be mindful by watching the CK level and also the cardiac status, because that will affect the heart also, because it will alter the whole cardiac rhythm. Then ABG. So the arterial blood gas analysis is very. If you're not able to get the arterial blood gas analysis, immediately we can do the VBG, that is venous blood gas analysis, to determine the hypoxia and acid base analysis, what abnormalities. This is one of the important things. No matter what burn injury, either the especially flame or chemical injuries, always suspect the carbon monoxide injuries or the any inhalation injuries. Look for the CO, that is carbon monoxide, because there is only one oxygen molecule. So urine analysis check the myoglobin and if it greatly increases, then it causes the acute renal failure. So any burn injury, especially second, third, or electrical burn injury, that really releases the when the muscles are damaged in the third degrees, automatically it releases the myoglobin, which is stored in the muscles, and that will damage the kidney. And culture and sensitivity studies, that is for the, we are in the later stage, not in the immediate stage when the patient admitted in the department, and as the time goes, we have to do the blood culture, sputum culture prior to the commencement of the antibiotic. Next one. And other investigation includes the chest X-ray. Please be mindful here. Chest X-ray, no matter what severity of the burn, initially it will be normal.
মোর খাতা আনলে এটা খুব ভালো শোনা আছে চলো মোর খাতা আনলে মোর খাতা কলম আনে দেও
Can I request all the participants to mute, please?
So as I mentioned, just to be mindful, chest X-ray will be usually normal in the initial stage in the emergency department, but at later stage, within the next 1 to 2 days of the injury, we can see the changes such as atelectasis, pulmonary edema, depending upon the percentage of the burn, and especially if the burn injury involves the chest. Can I request all the participants can mute your speakers mics, please? Bhargavi, Pradeep, can you mute your mics, please?
I'm not able to see them.
Nandini Singh. Nandini Singh, can you mute, please?
Bhargavi DS, please can you mute your mic, please?
Bhargavi, can I request you to mute your mic, please?
Anjali Rani Singh.
Who is she?
Can you remove that, Bhargavi, please?
I'm trying to look for.
Okay. So bronchoscopy is essential in case of the inhalation injuries. Pulmonary function test reduces the lower the values of the pulmonary function test indicates the severity of the inhalation injury. 12-lead ECG is very, very essential, especially in case of electrical injuries to assess the myocardial damage. And in the blood test, you can add the troponin also. So that also will be elevated in case of this myocardial injuries. Next slide, please. So how you can manage this burn injury? So I'm not going in detail, but we'll try to segregate the points because this is very vast topic. So initially what we can do is stop the burning process. Remember, it's not the only the nurse's responsibility, it's not the doctor's responsibility, it's a collaborative management. That's why I mentioned collaborative acute burn management. So all the team, doctors, nurses, physiotherapists, microbiologists, everybody is involved in the care of the burns patient. So initially what you have to do is stop the burning process. Either it can be chemical burn or no matter what type of burns, you have to stop that, take the patient away from the source. Or if the patient comes to the department, stop the burning process. I'll show the few basic things now. Consider the burn patient as a multiple trauma patient until determined otherwise. Any burns patient comes, imagine if I'm getting any burn injury, suddenly I will move my body and I'll fall, I may hurt my neck, always suspect the spinal cord injuries. Or in case of any electrical burns, what will happen? Imagine if any patient hold the electrical wire, a live wire. So what will happen is causes the transient tetanus condition. What will happen? There is a severe contraction of the muscles. The patient won't be able to leave that electric wire unless we turn off the power source. So what will happen? The patient will be holding the electric wire and there will be severe contraction of the muscles. Even that may cause the fracture. So always you have to be mindful or suspect the spinal cord injuries or injuries in case of any burns. Perform ABCD approach. So any major cases, it can be a burns or it may be cardiac arrest or it may be a trauma patient. Please remember the ABCD approach. ABCD means airway, breathing, circulation, disability, and environment or exposure. Next, remove the constricting clothing and jewelries. So once the ABCD is done, take out the cloths because you have to do the full assessment and also you should avoid any clothings or jewelries which is causing the restriction. Next one, please. So as I mentioned, ABCD approach can be divided into the two categories, primary survey and secondary survey. So these things you will be hearing at later stage also when we will do the trauma assessment or the cardiac assessment. Any patient comes to the emergency department with the critical conditions or even with a shock, still these things will be applicable. Primary survey and secondary survey, that is airway with cervical spine control, breathing and ventilation, circulation with hemorrhage control, disability, that is the neurological status, and exposure, that is environmental control. And the secondary surveys include the history, mechanism of injury, and head-to-toe examination. Next slide, please.
Slide को बता दो याके.
Parvati Asha, can I request you to mute, please?
The airway. So that is burned airway creates a problem by swelling and can completely occlude the airway. So we have to be very mindful. Imagine if the patient, stuck in the room, even though there is no burn mark on the body, But even the patient is inhaled the smoke also, still we have to be very careful. Should be treated as is major burn because we don't know what's going on inside the throat. So secure the airway with the endotracheal tube until swelling subsided. Usually take 48 hours. So ET tube is essential. And delayed diagnosis of the airway burn make difficult to intubate. So as soon as patient comes to the emergency department or casualty, suspect the airway injury and keep the stuff ready, keep the ET tube ready, and always keep the smaller one also ready in case if you're not able to insert the 7 or 7.5, so go for the smaller one. And early intubation is suspected of airway burn is the treatment of choice in such patients. That is delayed, what is it? If you're not able to do the intubation, then you have to go for the cricothyroidectomy. That's one of the immediate and the safe procedure for the patient. And usually you can see in the emergency department this procedure when we fail the definite airways. Next slide, please. So always maintain a low threshold. That means keep everything ready for the intubation always, but suspect the airway injuries. Always, even the patient looks normal, but still suspect the airway injury because that's very difficult to handle once we identify it at later stage. Swelling is very rapid and progressive in the first 24 hours. That's why I said once the intubation is done, so patient has to be intubated at least for 48 hours. Next one is prior to intubation attempt, have a smaller size endotracheal tube available, prepare for the cricothyroidectomy, and if that fails, then you have to go for the tracheostomy. And always use the end-tidal carbon dioxide, that is monitor the CO2. So when you connect with the patient monitor, so you can see the tidal, what is it, CO2 monitor. So what is the level of the CO2? So that will make usually for the assessment of the ET tube in place. Second one, so next slide, please. So when you have to intubate the patient or when you have to keep all this stuff ready for the intubation, one is when there is a change in the voice, wheezing or labored respiration, excessive continuous coughing, altered mental status. So altered mental status is one of the reason for what is caused by the hypoxia. Then the changes in the sputum, and you can see in the if you observe the nose or the face, in case of the any burn injury to the face, we can see the burns to the eyebrows, eyelashes, or if the male patient in moustache or beard, you can see the burn, or even the burns to the hairs. That's also a serious indication for the intubation. Or take a cotton swab and put it in the patient nose and just rub it and take it out. And if you see any carbon particle, the black soot, yes, straight away start the patient on oxygen, 100% oxygen for half an hour. Take the VBG or ABG, then keep the ready stuff. Keep the all the equipment ready for the intubation. Okay, stridor, uh, extensive burns to the face and neck, and eye swollen, or the burns percentage of burn is more than 50% or greater. They're all indications for the intubation. Next slide, please. So that is the airway. So once we have maintained, means like airway, once the airway is patent, is as patient can take the air inside, then you have to go for the breathing. That is, you have to observe the and record respiration rate, air entry to the both side of the lungs, chest, and you have to observe for the chest expansion, whether it's a unilateral or bilateral, color of the lips, that is for the cyanosis, that is color of the lips and skin, and assess the burns to the chest wall and chest compliance, and progressive uh, increase in the respiratory rate, effort, and anxiety. So you have to monitor that also. Raise in pulse and confusion with the decreasing O2 saturation is one of the indication for the intubation, as I mentioned earlier. And it usually takes 24 hours to 5 days to appear. You have to be very mindful, especially if any injury to the face or inhalation injuries, patient won't be showing the signs in first 24 hours. Patient may look normal, so still you have to observe the patient for 5 days because the swelling usually starts after 24 hours. So treatment start as soon as possible, which includes the physiotherapy, nebulizer, warm humidified oxygen, But remember, thickness burns to the wall needs the escharotomies. So because there is a huge swelling, eschar means it is a dead skin, and it will be thick and it won't be elastic. So it's kind of a thick elastic band around the chest. The patient, even the patient want to breathe, there is no space for the expansion of the lungs. So at that time, you have to make a slits up to the subcutaneous tissue. So I'll show the picture at later stage. Next slide, please. So in circulation, what we can manage? Monitor the blood pressure, heart rate, whenever it is possible, try to put two 16 gauge cannulas in the non-burned tissue, not in the burned area, so in the non-burned area. And sometimes even you may have to go to the leg also. But when you put the cannula in the leg, in the lower extremities, always be mindful for the higher risk for the DVT, that is deep vein thrombosis. Here comes the most important part in circulation is the fluid resuscitation. Initially, if you go back few beginning like 100 years ago or 50, 60 years ago, the patient comes with a severe burn injury, especially in the war time, and they used to leave them in the ward because they know the patient is not going to survive. There is one famous story is there. What happened is that one of the junior doctor has been assigned with the third and severe burn patients. So what he has done, he started giving the more and more fluid because he has seen the patient losing too much of fluid because of the edema, because of the extravasation of the fluid, shifting of the fluid. So he started giving the fluid because initially burns patient they never used to get proper fluid because the assumption was that patient already the whole body looks edematous, so we should not give the fluid. But one of the junior doctor he started no, there is a huge loss of the fluid intravascularly, so he started giving the fluid. So that has given the huge recovery. So then they had that there's a huge research has been taken place, and they found out that yes, the fluid resuscitation make a big difference in patient prognosis. So I'll tell you in the next few slides how to calculate the fluids and what formula has to be used for the fluid resuscitation. And the fluid resuscitation to be used only if the burns percentage of the burns more than 10% in the children, that is up to 17 years, and the 15 more than 15% in the adults. And if the patient, imagine if the burn injury involves the lower extremity, that is legs, and patient is able to drink, so that's fine. Then you can give that much amount of fluids to drink, but ideally IV fluids. And if you're not able to get IV access, and if the patient is able to tolerate the oral fluid, yes, you can give the fluid water, but with electrolytes in place. That is diurolite. In India, I don't know what brand they're using. That's ORS solution. So whatever the brand you will get, you have to add, and you can give that one. And for IV fluids, most commonly what you are using is the ringer lactate, which is also called as Hartmann solution also. So don't get confused; both are same. Next slide, please. So what are the formulas are used in calculation of the fluid replacement? The one of the commonly used formula is the Parkland formula, and the other one is Evans formula, Barksdale's modified Brooks formula. There's so many formulas, but I'm going to cover only the Parkland formula today. So how it will be used? So that means whatever the fluid requirement is patient fluid requirement, the first half will be given in the 8 hours, remaining will be given in the second 16 hours. So the formula includes, that is 4 ml times percentage of the body burn area per kg. So for example, if the percentage of the burn is 10%, so 15% or 20%, times 4 ml times kg. What is it, depending upon the patient weight? So we'll have these few case scenarios at the end where I'll give you the opportunity for you to calculate and give the answer for the same. But remember Parkland formula. Next one, please. Okay, you are giving the fluids to the patient, which is one of the integral part of the management of the burns patient. So how do you know that yes, this is very effective for the patient? So that is when you have to monitor the patient urinary output. So output should be between 0.5 to 1 ml per kg per hour. So that means if the patient weighs 100 kilo, his output should be there 100 ml per kg per hour. So that should be, so ideally you have to go for the hourly monitoring. when you put the urinary catheter to the patient, always don't attach the plain urinary bag, attach the hourly urine bag. So it will be easy to adjust the fluids, and also it will help us to assess the renal function. So if the urine output is below, this infusion rate should be increased by 50%. So if a patient is getting, imagine like 350 mLs per hour, then the urine output, if you're not achieving this urine output, then increase the fluid rate by 50%. That means if the patient is getting 400 ml, so 400 ml of the 50% is 200. So that means 400 plus 200, 600 mLs you have to increase. If the still urine output is inadequate, then the bolus of 10 mLs per kg you have to give. If the patient, like whatever the kg, so you have to multiply that much amount has to be given. But mindful about the cardiac overload as well as the, yeah. So next one is 2 ml per kg per hour urinary output is signals decrease in rate of the perfusion. So hematocrit measurement, as I mentioned earlier, is one of the indicator for the status of hydration. Next one, please. Okay. So once we have done the ABCD, means like airway, breathing, circulation, then you have to go. Actually, there's a slight mix up here. So what other thing we can do is that we have to put the urinary catheter to monitor the urine output, and we can put the NG tube also for the patient tube, because the always there is higher chance for the paralytic ileus with patient with the burn injury of more than 30% or injury to the abdomen. And medications, what we can give is that except tetanus tox TT injection, all the medication ideally should be given through IV, because of the extension. It's all depending upon the extent of the burn injury. Prophylaxis, tetanus toxins should be given, and for the pain, morphine sulfate should be given. Ideally, zero point 0.1 to 0. Milligram per kg can be given. But remember, one of the most common side effect for the of the morphine sulfate is the vomiting. So ideally, give the cyclizine along with the morphine to avoid the vomiting. Then PPA, that is proton pump inhibitors, should be given. Bronchodilators, mucolytics, that is to promote to remove the secretions from the throat. Then the antibiotic. Initially, you have to give the broad spectrum antibiotic, but it's not required to give the antibiotic. Don't rush to give the antibiotic when the patient comes to the emergency department. This is secondary. So antibiotic, because patient will be clean. You can manage the patient. You can do the dressing. Then you can start the antibiotic at later. Antibiotic is secondary. The primary is airway, breathing, circulation, giving the fluid, painkillers. Then comes the antibiotics. Next slide, please. So diet, what kind of diet we can give to the patient? Because there's a huge loss of protein. So how you can increase that one? So to maintain the positive nitrogen balance, we have to give high protein and high carbohydrate diet. But if the patient is on a ventilator and the patient is ready to wean, at that stage, give the high fat and low carbohydrate diet, because high carbohydrate diet increases the CO2 production. So wound care. So the wound need to be cleaned. Debridement can be done through the manual or enzymatic or surgical. And antimicrobial therapy, that is commonly you're using the flamazine or the polysporin ointments. So there's all debatable, but still in most of the cases it proves it helps in the healing, wound healing. Next one is skin grafting and escharotomy. What is this escharotomy? So eschar means burned inflexible necrotic tissue. It's like a rubber. It's not rubber. It's kind of elastic, non-elastic band. If there is any injury to the severe burn injury to the chest, it's a circumferential. Circumferential means the whole area, like whole area will be burned, and what will happen, that will causes the non-elastic, it damages the skin, it forms the eschar. So it won't be the flexible. Now if I'm taking a deep breath, yes, the chest wall will expands and decreases, expands easily when you take a deep breath, but that won't be possible in case of the burn injury. So in that case, what's going to happen is, so next slide please. So you can see here, circumference means the whole circumference of the arm or the leg or the chest is involved. So in that case, so this procedure is performed, escharotomy. There are few videos are there which will be very disturbing to see. So you can see in your own time. I actually had one video for the escharotomy, but I don't think so everybody will be able to see that video because it's very disturbing. So if you're willing, you can see there are multiple videos are available in YouTube. You can watch that one. But I'm showing only for the arm. See here. So again here debatable. Few of them they suggest only put the slit incision up to the superficial layer only. But most commonly advisable is that up to the subcutaneous. You can see this subcutaneous tissue here. So you have to put the slit up to the visibility of the subcutaneous tissue to relieve the compartment syndrome. But sometimes it has to go more deeper, but all depending upon the expert's hands, depending upon the expert's opinion. Next slide, please. Next slide. Okay. So actually, as I mentioned, slides were a bit mixed up there. So I mentioned airway, breathing, circulation. We have mentioned that is A, B, C. Next comes to the D, that is disability. So in disability, what you are going to check, that is level of consciousness. That is you are using the Glasgow scale and you are checking the pupillary response also in neurological status examination and exposure to the environmental control. That is, so we have to, once the airway is managed, take out all the cloths and assess the patient head to toe. Keep the patient warm because there will be skin loss and there's a higher chance for the hypothermia. Imagine if you get a call, you are in emergency department, you get a call, okay, patient coming with a burn injury. Try to increase the heat. If you are living in a cold area, so increase the heating of the room to prevent the hypothermia. And then once again, you assess the total percentage of the body burn, then observe for the other injuries. Next one, please. So secondary survey. So we have finished the primary survey, that is A, B, C, D, E, and next one is secondary survey. So in secondary survey includes the history. So you have to take the details from the patient or the patient's family or friends who are or the witness. So what is the cause of the burn? What is the time of the injury? Place of the occurrence. For example, there is a flame injury there, which happened in the closed confined spaces. For example, if there is any burn injury happened in the bedroom, so always suspect the inhalation injury also. Even though there is injury to the hand, suspect the inhalation injury also because this incident happened in the confined places. Presence of chemicals or any likelihood associated trauma, for example, explosions. Then what are the interventions has been carried out pre-hospital. Then mechanism of injury, how it's happened, and do the full head-to-toe examination. In ABCD, first you are done only you are given importance to the airway, breathing, and circulation. Now you have to do the full head-to-toe assessment and document all the relevant findings. Next slide, please. So, patient family teaching. So, what are things we can educate to the patient, or what we can say to patient? 1 second, the slide is missing. So educate with the help of the physiotherapist, educate the patient regarding the coughing, deep breathing exercises, and incentive spirometry. So this all helps in the increasing the pulmonary functions. And also educate the patient what is the purpose, expected results, and anticipated sensation for all nursing and medical interventions, especially in the first and second degree burns. It will be very painful. Even if you're going to change the dressing, give the analgesics to the patient first. Explain to the patient, you are going to get the pain, but we are giving the painkiller to you. And if the pain is not, if the intensity of the pain is not going, we'll give some more painkillers. So assure the patient because the pain will be very severe. Then splinting and range of motion exercises with the help of the physiotherapist or your nurses can educate based on the education received from the physiotherapist to prevention of the contracture. Skin care, usually lubricating cream. In emergency department, what we used to do earlier, if any patient comes with the injury to the hand, so we used to apply the flamazine and we used to cover in the plastic bag and we used to ask the patient to keep moving the patient and every half an hour we used to change the ointment. We used to apply the ointment. We used to ask the patient to move to prevent the contracture. but now that's outdated, that's gone now. And remember, what is it? Any burn area will be highly sensitive to the UV light. So advise the patient not to expose to the sunlight at least for 1 year. That affected area should not expose. For darker skinned people, the permanent pigmentation changes likely occur because of the loss of the melanocytes, which are present in the dermis. So once it is done, that damaged, there's no any production of the melanin. So affected area will remain pink. And wound care includes the what is it, dressing changing procedure, and we have to advise the patient what are the signs and symptoms they have to monitor for the infection. Next one is what are the medication? A patient will be taking the medications even patient after getting discharged also, mainly the antibiotic or the main one is painkillers. So educate the patient regarding the what are those medication patient is taking, why the patient is taking medication, dosage, schedule, and the precautions and the potential side effects of each medications. And if possible, try to give the number. Is there any help group, support group within the local area? Give the number for the help. Next slide, please. So as I mentioned earlier, inhalation injuries. Also, one of the common inhalation injury, what we can see is the carbon monoxide inhalation, intoxication. So if any patient comes with a carbon monoxide in intoxication, so first and foremost is that you have to remember hemoglobin. So oxygen and the hemoglobin, so that is oxygen will be attached to the hemoglobin and that will be carried from lungs to the different part of the body. When there is a patient inhales the monoxide, carbon monoxide, instead of hemoglobin binding to the oxygen, two molecules of the oxygen, it binds only to the one molecule of the oxygen because it's having the higher affinity. That is 210 to 240 times greater affinity for this single oxygen molecule rather than the two oxygen molecules. So that means you can imagine, even if you're checking the pulse oximetry, still the oxygen saturation may show normal because pulse oximetry detects the oxygen. It won't differentiate whether it's having the one molecule of oxygen, that is the two molecules is required, CO2, okay, O2. But instead of the O2, it will be only one oxygen molecule. So still don't rely on the pulse oximetry. So always take the VBG, that is venous blood gas, or the ABG. Then run that one and see what is the carboxyhemoglobin level in the VBG. When as soon as you take the print from the VBG machine or ABG, you can see that what is the level of the carboxyhemoglobin. If it is higher, the first and foremost is that give the 100% oxygen for 30 minutes. Why 30 minutes means the half-life of the carboxyhemoglobin is, if I breathe the carbon monoxide and I'm affected with carbon monoxide, it will take 120 to 200 minutes for half-life to eliminate half of the carbon monoxide from my system. But if I give the 100% oxygen, it will take 30 minutes. It might not mean that 30 minutes you have to stop it. You have to continue it till the carboxyhemoglobin level comes to the normal or it will disappears. Next slide, please. So in inhalation injury, it can be carbon monoxide or it can be any other due to the chemicals or any inhalation injuries. One of the most definitive diagnostic procedure is the bronchoscopy. In the bronchoscopy, most of the times surgeons can find airway edema. Usually, as I mentioned, it won't be immediate, but expect that one in 24 to 48 hours, even can happen even within 5 days also. So always be mindful and be cautious about the airway edema. Inflammation, mucosal necrosis, presence of the soot or charring in the airway, like a blackish appearance, tissue sloughing, and the carbonous materials in the airways because of the burn injuries. And the early intubation is required if the features of the airway edema seen, and it will increase, as I mentioned, the edema will increase in the first 24 hours. Next slide, please. So what are the treatment for the inhalation injury? So one is bronchodilators, that is you can give the salbutamol for every 2 hours, and if the heart rate is very high, then you can give the ipratropium bromide. and nebulized heparin. Usually, I have not seen in the emergency department, but you're all experienced nurses also here. They might have seen in the chronic management setting heparin. So that will prevent the pulmonary clots. Then the hypertonic saline. Hypertonic saline means that is, for example, 0.45 is the hypotonic, 0.9% is the isotonic, and higher percentage of the saline, that is more than 9% of the saline will be given through the nebulizer. The reason is that acts as the respiratory irritant and it helps the patients to cough. But you have to be mindful, if there's a huge swelling is there, try to avoid giving the hypertonic saline because it causes the further irritation. And if the patient is not able to cough, then all the fluid, the secretions will be accumulated again in the throat and in the upper airways, and that will aggravate the condition furthermore.
Yeah,
And
sometimes
epinephrine can be given to reduce the mucosal edema.
It causes
Next.
bronchial spasm. 30% of the hypertonic saline sometimes can cause bronchial spasm. So you have to keep salbutamol as a backup as a bronchodilator nebulizer. We have done that few times. Yeah.
Next slide, please. Thank you, Mr. So, as I mentioned earlier, we are going to cover the Parkland formula more, how to calculate the percentage of the burn and how to start the fluid, how to calculate the fluid. So I hope I posted this Mercy Burns app in our student and teaching group as well as in the clinical group in the WhatsApp day before yesterday. Hope everybody got an opportunity to go through this one. So this is one of the best app what we are using commonly here. That is Mercy Burns app. So it will help us to calculate the percentage of burn, that is the full thickness burn or the partial thickness burn, and calculate the fluid. Straight away it will calculate. No need to use any calculator. It will do all the calculation for you. Next slide, please. Okay. So there's a small video is there. Sorry. Okay, it's okay. You can skip that one, please. It's okay.
Recognize. Continue. Do you want me to play this?
No, it's okay. If it's not playing, it's okay. If you're able to play it, that's fine.
I can't. It's not moving. Sorry.
It's okay. Can you make me admin, please? Just I want to share the screen.
Yeah. Rajendra, you are now there. No one.
Okay, good. I'm sharing. Can everyone see the screen?
Yeah.
See, this is what Mercy Burn. When you open the app, it will give the option for you to calculate either the FT means the full thickness burn or the partial thickness burn. So if you click full thickness, and if you see this is the front and the back. Okay. So for example, it's a full thickness burn we are going, and there is an injury here to the chest and neck. Okay. And also it includes the arm. And this part includes only the partial thickness, and you can see here partial change in the color. Okay, so now the percentage of the burn automatically shows here. Can you see here 15.7? So again, here is the partial thickness burn, partial thickness. So 19.6. So this will automatically calculate. No need to use the rule of 9 or other things. So it's very handy, very quick. Okay. So then it. Oh, this slide. You can see here, you can set the age. 1 to 17 is considered children and adult. You can set it here. and what is the weight of the patient. For example, patient weight is 100 kilo. Okay. And when the incidents happened, you can write the time or you can write now. Okay, you imagine patient comes to emergency department in 10-15 minutes, still it considered as now. So now you can see the option here. This is the fluid calculation. And see, now you can see the patient age, adult, weight 100 kilos, burn percentage, that is TBSA, that is total body surface area, the burns 19.6, injury happened now, burn time, that is now, and what is the fluid rate, that is 4 ml we are giving, that's full, that's not modified, it's a full 4 ml we are giving. So how much fluid we need? That is 3,920 ml to be given in first 8 hours, that is 490 ml per hour, that is nearly half liter for this patient per hour. For 8 hours we have to give, and remaining 3,920 ml should be given next 16 hours, that is 245 ml per hour. So this is for the resuscitation of the fluid. So that's why I said this is one of the most recommended app, Mercy Burns, for the calculation of the fluid and also for the calculation of the burn injury, percentage of burn injury. Can you see the screen?
Yes, we can. Yeah.
That's not taking for me also. Okay. This is only 34, you can see, as I demonstrated earlier. There's no sound. That's for the partial thickness. So who is having the option, who has downloaded the uh, Mercy Buns app, they can calculate now. So there is, sorry, my system is stuck. So okay, I have two case studies. So one is adult percentage of time of injury is 10 minutes ago, should be considered as now, and how much fluid is required for this patient. So patient is adult, 20% burn and 70 kgs. So how much fluid is required? So I have one, I'll give 1 minute time for you to calculate, and you can respond in the
Chat box.
কোথায় দেখাচ্ছে আর আমায় কোথায় দেখাচ্ছে ভাই আমার কোথায় দেখাতে পারছি কি
so
Where are
patient weight is 70 kilo. I'm doing the same thing now. using the app? And it's happened now.
In YouTube, answer already is here. Already is here, Rajendra. On
Oh, that's
YouTube.
good. Okay.
Yes.
So we
Okay.
got some answers here. 5,600 ml in 24 hours.
The same answer on
5,000?
600 ml in 24
That's
hours.
right, yeah, 5,600. So half of the fluid should be, that is total fluid requirement is 5,800 ml. Sorry, 5,600 ml. That is, the first half should be given in the first 8 hours. Remaining half should be given in the 16 hours. That is, 2,800 ml should be given in the first 8 hours. That is 350 ml per hour for first 8 hours. Then 175 ml per hour for the 16 hours. So that is the fluid resuscitation requirement for that patient.
Yeah, we had the same answer in the chat box as well. Well done.
That's very well done. Thank you. So next case study. My system is stuck. I don't know what happened.
You want me to take over?
Yes, please.
Okay, if you make me host.
Okay. I can't, stuck agidire ಅದು.
Okay, it's okay, don't worry, just carry
But
on.
still you can see the screen, isn't
Yes.
it?
Yes, we can.
Okay, so a second case study, a 38 years old patient present EED with a 22% burns, weight is 65 kilo.
Oh.
Suresh, you are the host now.
Is it? No, I don't have the slides. I'm changing to you. Tepesa, I'm changing to you. You're the host now.
Rajendra has dropped out, is it?
It look like. Can you put on that question, the second case study, please?
Sure.
I think Rajendra has dropped down. If he's back, I think you need to admit him.
Yeah.
So you can carry on that second case study.
Can you see it?
Yes, go to second one. Yes, I can. Yes, that's right.
So those who got the app, can you please make a, can you please work out the calculation? Oh, sorry. And you can either type your answers in the chat box or on the YouTube.
Can you hear me?
Yes.
Yes, we can.
So ಸ್ವಲ್ಪ ಹೋಸ್ಟ್ ಮಾಡ್ತೀರಾ?
ಇಲ್ಲ ಆಲ್ರೆಡಿ ಪೋಸ್ಟ್ ಮಾಡಿದ್ದಾರೆ ಬಿಡಿ, ಕೇಸ್ ಸ್ಟಡಿ 2 ಹಾಕಿದ್ದಾರೆ.
Okay, so second case study. Okay.
So
straight away. Okay. 65 times 22 times.
Rajendra?
Okay, you have 1 minute to complete this task.
I think we'll move on. It's time.
Okay.
Yeah. So.
Okay. So, but remember, if the patient injury happened 4 hours before, the fluid will retrospectively to be added to the patient fluid requirement. If the fluid requirement is 100 ml in the first hour, for example, as we mentioned earlier, 2,800 ml should be given in the first 8 hours, but injury happened 4 hours ago. So that means 2,800 ml should be given in 4 hours because already we lost 4 hours. So don't give the always consider the time of injury also. So take this last example. Once again, I'll repeat. If the fluid requirement is 2,800 ml first 8 hours and injury happened 4 hours ago, that means the whole 2,800 ml should be given in 4 hours instead of 8 hours.
Rajendra, there is an answer on YouTube for the case study 2. Lakshmi AN answered 2,860 ml.
Okay. So remember the same formula, that is percentage of the burn. So that is how much fluid we need, 4 ml per hour. So 4 ml times 22 plus 22 times 65. That is 622 into 65 into 4. So whatever the fluid will come, so divide by 2. That is half should be given in first 8 hours, remaining half should be 16 hours. So remember Parkland formula, but it will be more ideal if you use the Mercy Burn app in your phone. It's available in both iOS and Android.
Is it the right answer, Rajendra? 2,860 ml.
Yeah, I'll check that one second. I didn't get a chance to check. Can you make me a participant, please?
Admin, you mean?
Admin, sorry. $2,860.
Yeah, that's the correct answer.
Yeah.
Yeah, you are now the host.
Okay. Thank you for listening. And we'll take any question. This is now question and answer session. If you have any question, please feel free to ask, please.
Before goes to the our Zoom, I have got a couple of questions on YouTube viewers. There are two questions from Lakshmi AN. There's a one question is about please define cricothyroidectomy.
Cricothyroidectomy. Cricothyroidectomy.
It is the it's not advanced as the tracheostomy. It's putting this small slit between the two ligaments in the cricoid process. So that is only the temporary. If you're not able to intubate the patient by using the ET tube, or if you're not able to use any smaller ET tube, or if you're not able to put any advanced airways, can be a LMA or anything, then it is to maintain the breathing, to maintain the airway, you have to put the cricothyroidectomy. If that is not done, then we have to use next procedure is the tracheostomy.
And then how do we warm children if they are suffering, if they were experiencing chills? That's the second question.
So the room should be very warm, and the blankets, special warm blankets are available.
Can we use bare handers?
We get the specialized equipment. If there's a full body burned injury, then we can't cover. So there is a specialized equipments are available where we can keep it. It's like a small dome. We have to keep it over the patient bed. Then we have to cover that one.
Sure.
Or you can again on top of that you can keep the bear hugger. That is a special warming blanket, either chemical warming blanket or the mechanical warming blanket. Different blankets are available in Ireland. I'm saying.
Am I right in saying we can use
ready pack? But the moment it will open, it will. There's a few chemical pouches are there in between, so that will interact with the atmospheric air and start heats up. So that will be the blanket will be warm for 4 to 6 hours.
Can we use silver foil or silver foil?
More ideal is the cling film. The
cling film, yeah.
Cling film, especially in first injury, first aid. At home, if any burn injury happened, clean first, cool the area. the most beneficial one is and more proven area is that proven method is standing under the shower or the sink, just running it clean tap water, cold water. Okay, but meanwhile, if the hand is affected, try to cover the body, rest of the body, with a warm or blanket or something at home. Then the whole area need to be cleaned under the running water, cooled it down. That is to prevent the further damage to the underlying tissue. Then use the cling film, the thin plastic sheet. What we'll be using in the kitchen. I don't know in India how.
Which degree is more painful? There's a question in the chat box.
First degree will be the more painful. First and second degree. Second degree superficial burns are more painful.
Another question: how should we treat patient?
So before I take the question, 1 second. If I use this cling film, that's plastic sheet, don't wrap it around the patient body because there will be edema within the couple of hours. So that will damage furthermore. So just keep it over the layers, like 1 layer, 2 layers, 3 layers. That's fine, but don't wrap it around the, especially around the arm, chest, legs. Don't wrap it. That's most ideal. So sorry, next question, sorry.
Sir, can you hear me?
Yes, I can hear. Please go ahead.
Good afternoon, sir. Why Arl is important in burns?
Yes, yes.
Which one, sorry?
Why ringer lactate is more important in burns case?
Ringer lactate are more balanced it is because it contains the lactate and also it more it gives the more nutrients in the sense that it maintains the electrolyte balance compared to the normal. Normal saline contains only the sodium and chloride. Here means it contains the lactate and other active ingredients, maintains the homeostasis. Homeostasis are it contains the resembles the plasma. It's not real plasma, but resembles the plasma.
Yeah, it decreases the metabolic acidosis.
Acidosis. Yeah, because of it contains the lactate.
It may, if the patient went for cardiac failure or renal failure, it decreases the value of the impairment.
Yeah, obviously it prevents organ damage. It minimizes organ damage if you are replacing the fluids with electrolytes essentially.
What happens, sir, in case of burns, electrolytes is lower side?
You will, well, like you said, you yourself mentioned it leads to organ failure. It increases metabolic acidosis. Respiratory acidosis leads to metabolic acidosis. Then you'll develop. Then you start to have organ failure.
So if there is for example, as I mentioned earlier, if there is increased potassium, decreased sodium, so there will be changes in the oncotic pressures at the cellular level. So there's the abnormal fluid movements from the intravascular to the extravascular space. So you can see more edema, there's more fluid in the extravascular space, and the less fluid in the intravascular space. So hypovolemia, distribution, it will cause both hypovolemic shock and in turn other conditions also will lead to the distributive shock, and end result will be the end organ failure,
leading to renal failure.
Sir, can you tell me the 5 signs of burns?
Sorry?
5 signs of burns.
What do you mean by 5 signs of burns?
Yeah, it is in, sir, blisters, pain. You didn't told that, sir. First thing only.
No, the signs are the clinical presentations all depends upon the degrees of burn and what is the cause for the burn. So all depends. Signs and symptoms of the patient will differ. For example, if the patient comes with the touching with the liquid nitrogen, so his symptoms will be entirely different compared to the flammable injury burn. So it's all we have to take into the consideration. For example, if the patient comes with the electrical burn injury, he will be having only 2 wounds. One is at the entry point, and one is the exit point. But he will show the signs of the cardiac arrhythmias because of the electrical disturbance in the heart. So that symptoms won't be available in the first degree burn because of the sunburn. So these all clinical symptoms will differ. So you have to use your clinical judgment your clinical experience, and what you have learned in your during your student period. So all the knowledge you have to bring it together, and it has to be individualized assessment.
Sir, which one is preferred in burns case? Either keeping dressing over or keep it open?
That is a myth. So people will say that no, leave the wound open, but
Yeah.
there's higher chance for the infection and higher chance for the scar formation. And there are several research proven. Always keep the wound closed. The higher the moisture, not higher, the right moisture and the right temperature is essential for the enhanced wound healing, granulation, and also to prevent the further scar. If we leave the wound open to the, I know there is a fresh air should be there, fresh sunlight should be there, but always there is higher risk for the scar formation and high risk for the infection. So it's always advisable wound to be closed.
There is a question in the chat box. How should we treat a patient with a partial thickness burns, less than 10% of their body, but poor vascularity?
No, in the partial thickness burn, that is the superficial burns. That is first degree. There won't be any vascular compromise, because that's why you are able to see the capillary refill. Always there is a blanching. The moment there is a blanching, there's a capillary refill. So that means the capillaries, that is blood circulation, is not compromised.
Okay. Any other questions from anyone else?
Yes, there is one question. Rajendra, there is one question from YouTube. Explain more about color of carbonaceous sputum.
So carbonaceous sputum, it will be blackish. So it's more carbon, so it's a kind of tar appearance. Or sometimes it's mixed with the blood, then the color will change because of this edema. There will be oozing of the fluid, so the changes will be there. So you can see, if you open the few YouTube videos, you can see that, especially the live bronchoscopy videos, you can see that how the changes depends upon the severity of the burns, smoke inhalation.
Thank you.
Anyone else has got any questions?
Sir, as a nurses, how to manage the airway, sir, as burn cases? Airway management.
Already I mentioned in the airway management. I think you might have joined lately, I think.
No, so you told only intubation, sir. Before that, what is nurses management, sir?
So first of all, that's what I mean. So here, once the patient is, suspect the cervical spinal injury in all the burns patient, because if I get electric shock, I said there's a severe muscle contraction that may cause the fracture. Or if I get any burn injury, I'll be running around everywhere and I'll be falling without my knowledge. I'll be falling and I'll be hurting. So first one is stabilize. Keep the patient the C-signs stabilization is most important. Then look for the airway. If any swelling is there, you can't do anything. Swelling has to be, if the airway swelling is there, nurses can't do much. So only thing that you have to arrange the equipment ready for the endotracheal intubation. That's the first priority.
Oxygenation.
Because swelling, we can't put our finger and we can't keep the airway open. So that's the first priority. If there is a airway blocked, that's the only alternative, first priority. Then cricothyroidectomy, arrange for the cricothyroidectomy. If that is not done, tracheostomy. So as a nurses, we have limitation. Even not only me, nurses, even if there is anesthetist comes also, he can't, if the airway is swollen, he can't do anything without putting the definite airways in place. But meanwhile, you can give the oxygen to the patient through the rebreather mask or the venturi mask. How best it is possible, give the oxygen to the patient. And if the patient comes with inhalation injuries, even though in that case I mentioned earlier, take a swab, cotton ball, put it in patient nose as deep as possible and swipe it and look for the change in the color. If there is any black discoloration or any burn marks on the face, suspect burn injury, take the blood sample immediately. If you're not, as a nurses, we are not allowed to take the arterial blood gases, but we are allowed to take the venous sample. Take the venous sample, go to ICU or go to CCU where the ABG machine will be there and look for the carbon monoxide level. And if the carbon monoxide level is, I don't know what parameters are we using in India regarding what is normal level, I don't know in India, but we have different reading methods here. So look for the normal level. And if it's elevated, use the rebreather mask, give the 100% oxygen to the patient. Technically, it's not, none of the oxygens are 100%, but we'll call it as 100%. Give the via rebreather mask, give the full oxygen to the patient for at least for half an hour, then recheck the, take the venous sample again, repeatedly check it till the carbon monoxide level, carboxyhemoglobin levels goes down.
Rajendra, there is another question, if you have a time. What are the 6 C's of burns care?
I'm not sure, to be honest. There
6
are,
C's.
see, burns is such a vast area. Everybody comes with their own ideas, their own theories regarding the management. So if you go to the US, they have a different way of presentation or taking the things into. So to be honest, I don't know what are those 6 C's.
Right.
I think
so, but 4 is they found out that question asked 6 is they might have Googled it. So they might have got the answer at that stage only.
Okay. Yeah. Rajendra, can you exit the screen? So,
Yes.
Yes,
sorry. Okay. So I need to show a few things. So in the dressing, as I mentioned, so can you see all of you?
No. Because of your background.
Okay, I'll take out the background 1 second. Okay. Can you see?
Yes.
Now? Okay. So this is the one of the, it's called as water gel. So which we are using in the emergency department, and you can see the picture. It will be like this. I am going to open this one now, but it will be messy. So this type of dressing is available. This is for the small burn injury to the arms or to the leg. But if any facial injury, we'll get for the whole face, and we'll get bigger pack also for the chest or abdominal or back injuries. So this one we are using immediately when the patient comes to the department, this type of gel. So I'm going to open this one now. So before that, I had to put the Inco sheet because it will be messy. I'm opening this pack now. Just peel it. And the moment you open, it will be like this. Okay. Can all of you see this one?
Yeah.
Yes, sir. Using.
See the gel? See the gel? Okay. It's very cold to touch, actually. So it will be very cold. Just you can wrap it around, and you can suddenly feel the like a decrease in temperature at the surface area because of the cold. So okay. So again, inside the pack also there is a gel. Still gel will be present. So we'll pour that gel on the patient. See here. Okay. So once this is done, we'll use the roller gauze and we'll wrap it at least for half an hour to 1 hour, and we'll leave it in the department. But we can't leave it more than that because it will lose the heat as a cold and it will start warming up. So before it warms up, you have to take it up. Okay. So once this is done, okay.
Sir.
Yeah.
So
you can use the non-adhesive dressings. So one of the common, whatever you are using in India, you can use, but commonly what you are using is the Mepetil, called as Mepetil. Just to take out, and they're all non-adhesive dressings. So use the sterile gloves and sterile equipment when you're handling this one. So just to stick it on the wound, and it will be sticky. Very sticky it will be.
It won't. It will stick around the edges, but it won't stick the wound.
So you will see. So when you're doing the dressing change also, it won't damage the underneath wound. Even no matter whether it's a 1st degree, 2nd degree, 3rd degree, it won't damage this skin or wound. So once the wound is healed or nearly healed, this dressing can be left for up to 2 weeks also.
Do we need a secondary dressing on it?
Oh yeah, definitely we need. No, this is only for non-adhesive sewing. Then
No, I just
after that
wanted
you
to
can use
confirm.
the surgical pads or the sterile gauze. Then again you have to go for the roller gauze for the protection.
Okay.
And if there is huge exudate, then you
Yeah.
will get the different dressing to put it on over that one to absorb all the exudates.
ಸರ್
Yeah.
ಇಲ್ಲಿ ಕನ್ನಡದಲ್ಲಿ ಹೇಳ ಸರ್.
ಹೇಳಿ
ಸರ್ ಈಗಿನ ಇರಲ್ಲ ಆಕ್ಚುಲಿ ನೀವು ಸನ್ಲೈಟ್ ಕುಂದ್ರಿಸಬಾರ್ದು ಅಂತ ಹೇಳಿದ್ರೆ ಸರ್ ಸೂರ್ಯನ ಕಿರಣಗಳಿಗೆ ಆಕ್ಚುಲಿ ಇಲ್ಲಿ ಏನ್ ಮಾಡ್ತಾರಂದ್ರೆ ಯೂಶಲಿ ಸ್ನಾನ ಮಾಡಿಸ್ಬಿಟ್ಟು ಕ್ಲೀನ್ ಆಗಿ ನಾವು ಸನ್ಲೈಟ್ ಎಕ್ಸ್ಪೋಸರ್ ಗೆ ಕಳಿಸ್ತೇವೆ ಅಪ್ಲೈ ಕ್ರೀಮ್ ಎಲ್ಲ ಅಪ್ಲೈ ಮಾಡ್ಲಿಕ್ಕೆ ಆಗಲಿ ಎಲ್ಲಾನು ಆಗಿ ಇಲ್ಲಿ ನಾವು ಆಕ್ಚುಲಿ ಡ್ರೆಸ್ಸಿಂಗ್ ಯೂಸ್ ಮಾಡಲ್ಲ ಸರ್ ವಿ ಯೂಸ್ ಟು ಯೂಸ್ ಇದೆ ಸಿಲ್ವರ್ ಎಕ್ಸ್ ಆಯಿಂಟ್ಮೆಂಟ್ ಅಂತ ಹೇಳಿ ಅದು ಪೆರೆನ್ಸಮನ್ ಏನೋ ಹೇಳಿದ್ರಲ್ಲ ಸರ್ ಆ ತರ ಯೂಸ್ ಮಾಡ್ತೀವಿ.
Still it's debatable it is. So we have discontinued the use of the flamazine because there is no 100% evidence that will help in healing. There are few cases, yes, it helps in healing, but not 100%. Not all the studies shows that it helps in healing.
But ಯಾಕೆ ಸೂರ್ಯನ ಕಿರಣಗಳಿಗೆ ಕರ್ಕೊಂಡು why we should not expose them to sunlight exposure?
No, sunlight. I'm not saying that we should not expose to sunlight, but there is higher risk of infection when the wound is open. Okay, and as I mentioned earlier, if there is a second and third degree burns, second degree deep burn and the third degree burns, always there is chance of blisters or the scars will be left behind. So higher risk of the scar formation if it is exposed to the UV light. So again, whatever practice you are doing, so if it's that's best suits to the current environment, absolutely go ahead. But what just we are trying to transfer the knowledge what we are practicing here.
What can I just ask? What is the reason for taking them out to the sunlight? ಇದರಲ್ಲಿ ದಾವಣಗೆರೆನಲ್ಲಿ
last 5 years I think 5 years
It's not audible clearly.
Now, do you take them to the sunlight early in the mornings just to get them some vitamin D?
Yes.
Yeah. Okay. So okay, hopefully you don't take them in the middle of the day.
Even though if it is only because of the vitamin D,
Yeah.
No.
then if you see the pros and cons, then we can give the vitamin D supplementation without exposing the wound to the infection.
Yeah, I mean, vitamin D is it has got anti-inflammatory effect on every
anti-inflammatory and also
diseases. Yeah.
But again, if you can get artificial cholecalciferols straight away.
Yeah.
Rajendra,
okay. Any other questions?
Rajendra, there was some advice to the nurses from the doctors. There's a question here. Some doctors advise to keep warmers. Is it good?
Warmers.
Warmers. Yeah. Warm.
That's the body warmers, isn't it?
Yeah, I just said warmers. I don't know. That's the body or whatever. Yeah.
Suresh, you're muted.
Yeah, it said warmers.
So warmer just because there is a loss of skin and there is no proper thermoregulation, loss of thermoregulations. Of course, the warmer is advisable. And again, somebody asked earlier how to maintain the patient temperature, prevent the hypothermia. So if the patient, remember in the 3rd degree burn, 4th degree burn, you won't be able to see the pilocarpine reactions, or you won't be able to see the patient shivering much. But still core body temperature will be very low. So in that case, give the warm body fluid, not the cold one. Okay, and don't use the saline to clean the body. And don't check the surface body temperature, check the core body temperature. Either rectally you can check, that's more ideal and accurate information regarding the core body temperature.
Before we conclude, just a quick few things to say. Those who haven't joined a clinical group in the WhatsApp, it's better if you have any questions, you type it up, and you can send the questions in the WhatsApp group as well. And those who haven't joined the WhatsApp group, kindly join so you can exchange your ideas. And also, it will be useful for us to improve and let us know before the presentation what is that you want from this topic, so we can explore that. It will help us to prepare ourselves as well, especially for clinical